This conference will now be recorded.
Thanks for sending that. All right, let's see. All right, so we're going to cover chapter 28. So we're going to do the head and spinal injuries, kind of continuing with our trauma assessments that we've been working on. With that being said, hit the right button, we can probably move forward. So obviously with the same thing as before, we're going to cover the National EMS Education Standard competencies following the DOT standard. With that and treating the acutely ill, injured patients. Except now we're going to focus more on the head, facial, neck, and spinal trauma. So we'll talk about C-collars, spinal assessments, how to do spinal rule out. And then today we need to cover the New Hampshire spinal assessment in person today. So when you guys come in next Sunday, hopefully you guys can all make it next Sunday. What was that? I can't hear over the radio. Sorry. Oh, pairs, yes. We have pairs coming up also, yeah. I'm not sure which, I look at the schedule if you guys which day it is, but yeah, we have pairs coming up. It's a good pediatric class you guys should all be there for. We're going to talk about recognition and management of life threats and then spine trauma, how we're going to treat it. And we're going to talk about the national standard and then what New Hampshire and Maine do for that. The pathophysiology and assessment and management of spinal trauma and skull fractures, how we're going to handle that in the field. The pathophysiology and assessment and management of traumatic brain injuries and spinal cord injuries as well. So kind of going back to the introduction of this is the nervous system is a complex network of nerve cells that enables all parts of the body to function, including the brain, spinal cord, and several billion nerve fibers. Still early, I'm moving words around too easily here. So with that being said, our body runs on something called dermatomes. You heard of that before? Heard of dermatomes before? You have before, where the nerve fibers, billions of them, all based on sensory, going to the cervicals, going to the spinal column itself, and up to the brain stem until you say, hey, that hurts. So if I pinch here, it runs through a certain dermatome that goes to the spine and transmits up to the brain and say, hey, stop pinching. So we'll go over that here shortly in regards to how that system actually works. The nervous system is also well protected. So the brain is protected by the skull. So we have a pretty solid bone structure up top of the head that protects our brain. Remember, our brain kind of just sits there, and it sits in like water, right? The spinal fluid in the water. What was that? Like floating, pretty much. And that's when we talk about different injury patterns that we can see here. It's sitting there. So if you were to take a walnut and put it inside of a water bottle and fill it halfway, right? You take it and you shake it like this, and you see the walnut go back and forth, right? That's what your brain is doing in motor vehicle accidents, or if you have any kind of head trauma. It's going back and forth, causing multiple contusions inside the brain, and which we will discuss more in the traumatic brain injuries and how that process actually goes. The spinal cord is protected by the spinal canal. So the spinal cord, right, is between the vertebrae and the spinal canal going straight down, so it's well protected. Until we have an injury that can cause any kind of shearing or any kind of swelling, and that's what causes our paralysis that we're going to see. Anatomy and physiology behind this is the nervous system is divided into two anatomic parts. We have the central nervous system, so think of it as your central column, like the highway. So it starts from the brainstem, works its way right down the spinal column. And the peripheral nervous system goes to the sides, kind of branches around and going down to the arms, the legs, everything else. That's our peripherals. Think of peripheral IVs, things like that, whatever. It's all outside, external from your core, right? So the central nervous system straight down, peripheral goes to the outside, and that's how things transmit through the nerve fibers that are there. So if you touch your hand like this, and you touch your body, you can feel the pain or the pressure because it's pushing through and letting your brain know, hey, there's something going on, right? So looking at this slide here, so we talked about the sensory and motor areas of the brain, right? So we have the brain that says, hey, this is what's going on. Hey, you're touching me. Hey, stop doing that. Stop stabbing me with this, or this burns. Ouch, this is hot, right? So the spinal cord, we'll start from the very beginning though, because this is where it ends up. So if I'm holding, as you can see here, so nerve endings extend into the extremities here. So he catches a baseball, right, barehanded. Smart move, right? What happens here is that the nerve transmits through the body up to the spinal cord, so peripheral nervous system, central nervous system, to the sensory part of the brain. They go, ow, that hurt. I felt that impact on my hand. Okay, so why is this important to know? Why would you think this would be important to know? To make sure you can feel this, you can feel this, you can feel that, the sharp, the dull. CSMs, exactly. That's our motor function, but as well, but our sensory, right? Do we have the potential for a spinal cord injury because we don't have the sensory functions that we're feeling while doing our grip test? You know, is this sharp or dull? You pushing the arm, pushing the hands, you know, and we're looking at that as part of our neurological assessment. It's no different than we talk about strokes. We start doing this, we start feeling the cheeks one side or the other. Does this feel different than the other, right? If this is feeling different than the other side, then we have a sensory issue, right? That could potentially be the stroke on the opposite side of the brain not getting be able to work on that sensory function. So that's why we check CSM's uppers and lowers by pushing our feet down, back up. Can you feel me touching your foot? Does it feel sharp or dull? Which toe am I touching? You know, from big toe to little toe, things like that. So that's kind of part of our assessment. So as it's coming through, and it's kind of right, the peripheral nerves come in to the central nervous system here, where your spinal cord is located. The sensory impulses go to the brain, and the brain says, yep, that probably shouldn't happen anymore. Let's stop that. Ouch, pull your hand away. It comes back down, and then that gives you the reflex that pulls it away, saying, ouch, it's a hot object. So with all that being said, it's important for us to make sure we assess that on all of our patients. Anything with a motor vehicle accident, anything that involves any kind of trauma, so this is a trauma lecture, we want to make sure we get that upper and lower CSMs, but also we want to make sure we're checking the CSMs, the sensory part of it, even when we splint. Cervical collar is considered a splint. And when we backboarded people back in the day, and we still do it now, depending on extrication device or not, it's still considered a splint. If you put a patient, so now what we do for motor vehicle accidents, we collar them, we stand, we turn, we pivot, we sit them down, right? Put them under a stretcher. Our stretcher is still considered a splint. So you still have to check CSMs after they're back because they've made some movement, okay? If you put a splint on an arm, same thing, CSMs prior to, and then after the back. We want to make sure that the sensory part of it is working, also motor and pulses as well. That's why it's so important to make sure you're checking that nervous system, make sure that there's not a disconnect somewhere, okay? Also, though, if you have a major fracture somewhere, even like the arm or whatever, it could take away that sensory movement from down below based upon the fact that it's actually shifted as well, right? The bone can break, shift.
You don't try to, like, you have no sensory.
To realign it?
Yeah. Yeah.
Yes, we do. So if we have no pulses, we have no sensory, no motor, okay, and we can have no motor, it's perfectly fine, but if we have no pulses down below, now we're getting circulation, at that point in time, we have to do that realignment. That's just pulling traction to see if we get to realign. That's why we always pull manual traction on femurs, because the muscles and everything else inside the femur, plus the bone, is such a powerful bone that when you break it, I know you guys can't see my hands here, when you break it, it kind of shifts and does this. By doing that, has potential for severing of major arteries, also the nerve endings and sensory and everything else, right? So that's why we pull manual traction, it does this and goes back into place, okay? Once you let it go, it goes back. That's why we got it. That's only for mid-shaft. That's why we use the traction splint to kind of hold that pressure back. Because it's such a powerful muscle in the leg, and everything just wants to pull. So the brain also, so the central nervous system includes the brain, obviously, right? The brain stem and the brain going down. We'll get the brain divided areas here in a second. That goes right down the spinal cord. The brain then controls the body and its center of consciousness. The brain controls everything. That's our mothership. That's it. It's there. That's what that controls everything that we do. What we think, what we say, our vision, you know, sensory, our motor functions, everything is done through the brain telling us how to do certain things. The brain is divided into three major areas: the cerebrum, the cerebellum, and the brain stem. Right. If you look at this picture here, mouse back here. So we have the spinal cord that runs down below, work our way up. We have the big opening, that's called the foramen magnum, which we talked about before during A&P. We go up to the brain stem, which runs through here, right? And we'll talk about brain herniation, and when our brain stem herniates, when it bleeds and pushes based upon the intracranial pressure. We'll talk about that later on in this presentation. We have the cerebellum, which is here. All right, then we have our temporal lobe, so temple, the side of the head. Our frontal lobe, which is all through here. Then we have our cerebrum, which is here. The parietal lobe runs on the side. Occipital lobe runs in the back. Remember that our sensory functions and everything else run through the parietal lobe here on the side, but our occipital lobe, what does that cover? You guys remember? Vision, that's your vision center. So when we're doing a neuro assessment, we want to make sure we're checking pupils, but can they follow the pattern? So if I say to Kelsey in front of me, look straight at me, and follow my finger, and I do this, and I go back and forth, and I'm staring at her eyes, and I'm watching her eyes go moving around. We're doing an H pattern type check. Okay, we're making sure that she has good vision in all fields and able to move her eyes and follow commands. And then we start checking peripheral vision check on a neuro assessment. So we have her look straight ahead, find a fixed object, and I'll do this with my fingers. And what I'm doing for you guys online as I'm move my fingers in a motion like this, I'm going to the side. Let me know when you can see this. And I come from behind and just do that. And she says, yes, I can see it. What we want to make sure is they can have good peripheral vision. So I can see mine here, right on both sides. But the farther they go in, if they can't see it till here, now you got a peripheral vision issue. That's more of a neuro problem that we have, right? Okay, so these are patients that are involved in motor vehicle accidents. Check H pattern. You don't have to do that in the ambulance. Sorry. You don't have to do those in the car. Okay, we can get to the ambulance and then do your neuro assessment. All right, you can do a quick one. CSMs, can you feel this? Can you feel this? Anything feel different? But actually doing pupillary vision checks, everything else, we should get to the ambulance unless you're just checking for dilation. Okay, so get in the back of the truck, then check your different fields of vision to see if there's any more damage. When you have a patient involved in a motor vehicle crash, rear end collision, you have that the front to back movement, right? So what's happening to your brain? It's bounce, 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 bounce. Keeps going back and forth, causing multiple contusions. And what is that called? What kind of injury is that called? Do you guys remember? When you have multiple contusions here and back here. It's right there. I know it is. You're like, I've heard this before. Yeah, it's okay. No worries. So the contra coupe injury, which goes front and back, right? We got to prepare for that because that's significant. That can happen with TBIs, and that can cause multiple contusions in the brain, front and back. All right, how you guys doing online? You guys doing good? Yes, my chat box is open if you need to write.
Doing good.
All right, awesome. So the cerebrum controls a wide variety of activities, including most voluntary motor functions and conscious thoughts. Right, contains about 75% of the brain's total volume and divided into two hemispheres with 4 lobes. Right, so we have the parietal lobe, temporal lobe, occipital lobe, and the frontal lobe. Right, and it goes into, if you take a suture and go right down the middle from here to here, it branches into 2 hemispheres. Okay, so you just talked about a head bleed. You and I were discussing earlier, right? So when they do a CT on the head, they look for the bleeding here and how much blood is pushing on this, causing it to maybe shift. So have you ever heard of something called midline shift before? Have you ever heard of that term ever? Okay, or hemispheric shift is another name they can use. Push. So it won't split apart like this, but the pressure on one side will cause it to shift over. That's bad. Those patients usually intubated, unconscious. Probably not going to live from this type thing. Very high chance of death rate on this. But those are your major bleeds versus your simple bleeds. It's simple, it's still dangerous, but more isolated location here. But that can eventually change and make it even worse. And a lot of times when they're in that situation, a lot of times they're sent to TBI centers or neuro rehab and things like that. So just something to pick up on when you look at that. I wish I had some scans to show you. I do have some scans on a TBI program that I wrote, but I don't think there's anything in here. Okay, I'll show you different scans. So as you can see though, voluntary motor function. So for me to be able to do this and pick this up is voluntary. I'm picking an item up, by the way, on the table here. So I wouldn't be able to do that if my cerebrum was damaged, right? That's a problem. These people that are almost brain dead here, they can't pick stuff up. Yeah, right. Now we start losing involuntary stuff. What is that? What happens there? And you can't breathe because that's your involuntary muscles making yourself breathe and not breathe, right? So I can do things involuntary. How does that work? I just dropped Kim for a minute. She went. All right, moving forward. The cerebellum coordinates balance and body movement. So if my cerebellum is damaged, and this is something I want to pay attention to, if they're up and they're moving around, they're loss of balance. They can't keep their balance, right? And they can't do body movements. The brainstem controls most functions necessary for life. That's protected part of the central nervous system. With that being said, your brainstem runs back here, okay? And if you have any kind of significant damage to that, or herniation where it herniates, you can be completely paralyzed and or deaf, okay? Depends on where you break in your neck. So the way I always remember this and way is C3, C4, C5 keeps the body alive. So 3, 4, and 5 kind of run your respiratory system. So without that, you stop breathing. Remember, you have C1, which is your atlas. Yep, they're up top. They're usually C1 and 2 are protected, right? So you have your atlas, which is C1. And the way to remember that is your head being like a globe, atlas, right? Sitting on top of an axis allows it to spin, to do this. So C2 allows you to do this, go back and forth, up and down. That's your access point versus your atlas sitting on top. And then the C3 through 7, right, are just called C3 through C4, C5, C6, C7. Then we get into our thoracic area, which have 12 vertebrae, right? So and then it goes T1 through T12. Then what's next? Lumbar, right? You have your lumbar. There's 5. 7, you're 12, you have 5. Then you have your sacrum, right, which has 5, and the coccyx has 4. Okay, those are all fused together. They're one plate, right? So then you have 33 total vertebrae, but some of them are fused together. Your last 5 and your last 4, so 9 total fused. Not necessarily. You can break them. You can fracture them. The question is did it sever that spinal cord? Yes. So you can still have a spinal process, which is the back that comes off. So when you're feeling your own back and you feel the bumps, okay, that's a spinal process that comes off of it. You can break those. Question is that going to shift? They're very small. Will it shift over and get into your spinal cord and either sever it, or will it cause inflammation? Therefore, it's a temporary paralysis. They have to go in and surgically remove certain things, the parts that are there, and then make it so that way the swelling goes down. So you could have a motor vehicle accident and then be paralyzed from the waist down. And it might be something that's temporary, depending on spinal shock and also depending on the swelling that's going on inside of there. And they can give you medicine to help reduce that. Yeah. Yeah. Right. And it's still there. You're lucky. Very lucky. So as you can see how important it is to make sure these cervical collars are put on patients and that we get them onto the stretcher without excessive movements, right? Because longboarding, they found out longboarding is actually doing more damage because you're on that hard board, right? There's no give, which in certain situations like water rescue and that kind of stuff, that's good until we get them out of the water, out of the boat, and onto the stretcher. And now we roll them, get them on something a little more padding or comfort. You can use a scoop. Those are probably, so scoop stretchers, when I first started EMS in the late 90s, they were like, yeah, let's use them all the time. Then they went away. Backboard. Scoop stretcher sat on the truck collecting dust. You know, you were there with all that stuff, right? And then now, leave the backboards in the truck. Now we use the scoop stretcher again. I'm waiting for the day for mass trousers to come back. You know, it's going to happen, I'm telling you. But yeah, so, but we got to remember, we got to make sure we're protecting our spine. Okay, we need to do a good spinal assessment. So when people check the back, they do this, they go, no, take your fingers and literally walk the spine all the way down. And stop, people stop all the time at the lower back. You need to go almost into their butt crack. All right, you got to get down there. So so I mean, make sure you wear your gloves. But you go right down, and I go right down to about maybe this far down below the crack. It's the crack start. I want to get that coccyx. I want to feel it. Okay, put pressure on it. And that's very painful. Very painful. Coccyx fractures are painful. And that's just literally, you can sit down and fall into their butt and they fracture their coccyx. Yeah, it's a lot of pain. So just keep that kind of stuff in mind, and do an detailed assessment on your spine, because you want to find anything that potentially could be wrong with it. So the spinal cord is made up of fibers that extend from the brain's nerve cells, right? So the fibers come out, and they carry messages between the brain and the body via gray and white matter of the spinal cord. Okay, so the gray and white matter, they transfer stuff up, saying, ouch, that hurts, stop touching that, you fool, take your hand off the hot surface. All right. That's why we need to make sure. I think I've gone in depth already on spinal assessment, how important it is to make sure you're checking. Protective covering. So the entire CNS is contained with a protective framework. So we talked about the spinal cord coming down, and I'll show you guys that here in a second with the central nervous system coming up in 2 more slides. With that being said, the thick bony structures of the skull and the spinal canal withstand injury very well. I mean, we take a beating and our spinal cord stays intact, but there's only so much force that can be applied where something has to give. And usually something like a car hitting you, it's a lot of, and even so, people get hit by cars and get up and they walk away and they're perfectly fine. You know, it's a very strong structure, but it can be fractured. So don't write that off. Actually do a good assessment. The central nervous system is further protected by meninges as well. So meninges are the outer layer, the dura mater, which is a tough fibrous layer that forms a sac to contain central nervous system. And the inner 2 layers, the arachnoid matter and the pia mater, contain the blood vessels within that. So I'm going to show you guys that here in the next slide. Keep in mind that the meninges can also cause inflammation and infection, right? And that would be called meningitis, which is highly contagious if it's viral. Bacterial, I mean, add it backwards, bacterial. Bacterial meningitis, it's done through air. It can be airborne, you can touch it. So you don't want to have, viral meningitis is different. That's not contagious. It's the bacterial one as well. So it may not be from an injury. It just could be inhaled infection causing meninges to become inflamed. But if it's bacterial, fever, stiff neck, and we talked about that. I think we talked about it already before. You do your chin to chest, and they have, oh God, extreme pain. And then they could be light sensitive as well, if photophobic. So they're staring at bright lights, and it hurts really bad. Yeah. So this is the central nervous system here, looking at the brain and all the different matters that are in here. So obviously we have the skin on the top, the first layer, then we have the fascia going into the muscle, all right? And then the outer table, inner table, which is your bone area, bony structure. The dura mater, all right? We have the arachnoid. Inside there is cerebral spinal fluid. Then we have our blood vessels that run through here. Yes, it's this whole layer here. Okay. Then we have our pia mater, which sits here. The blood vessels sit here. The brain is in here. Now, we start talking about head bleeds, okay? We have something called a subdural. We've heard of subdural bleeds, okay? That's sub in the dura mater. We would bleed in here. Arachnoid bleeds would be in here, okay? So those are going to be your different types of bleeds. Then we have our cerebral spinal fluid here. How do we check for cerebral spinal fluid? If we were to check that in the field, not that we would do it all the time, if we were to do it, the halo. And how do we do the halo? What do we put it on? The best one to utilize is your 4x4s with that mesh, right? You collect a drop of blood, and what will happen? The fluid coming out, and the blood will stay like in the center of the dot, and it'll become like yellowish on the outside, like a ring, the halo effect. If it's dripping, yeah. Blood dripping, just collect it and look at it. Good tool to utilize, but don't make it your end-all be-all. Treat the patient. I mean, you can't stop that. And if fluid is coming out, a lot of times it's because of intracranial pressure as well. So you don't plug it. It's coming out for a reason. Kind of like nosebleeds. You're bleeding for a reason, right? But if you're going to stop it, you gotta make sure they lead forward so it doesn't go down their airway. So cerebral spinal fluid, or also known as CSF, produced in a chamber inside the brain called the third ventricle. Okay, that's where CSF is produced. Approximately 125 to 150 mLs of CSF in the brain at any time. That's quite a bit, right? 150 mLs. And this primarily acts as a shock absorber. So it kind of helps when you have, remember I mentioned earlier, the fluid, okay, that's in there. So it kind of helps in the shock absorber to kind of help you out. So mostly back here. There are 31 pairs of spinal nerves. They conduct impulses from the skin and other organs to the spinal cord. They conduct motor impulses from the spinal cord to the muscles, and they also spinal nerves also serving the extremities are arranged in a complex network. And we talked about this with dermatomes as well. So looking at this slide here, as you can see down the middle is your central nervous system here, your spinal cord, and everything branching off, which is like all the brachial plexus coming off of here, and spinal nerves coming off. And more again, this is your lumbosacral plexus, brachial plexus. Everything comes, these are your peripheral nervous system. That's what I'm trying to get to. So it all starts with the cerebrum, cerebellum, and the brainstem. This covers all your motor function, sensory, talking, and voluntary movements, and all that. Into the brainstem coming down through the foramen magnum, which is the massive opening hole. That's where your brainstem sits here, and it comes straight down through. All right. Then you have your spinal column, central nervous system, that breaks off into your peripheral nervous system through the brachial plexus, lumbosacral plexus, branches down, goes down your legs, arms, everywhere else. That's your peripheral system. Okay. They kind of wrap around, and everything just transfers back through the nerve functions, the fibers, come back through to the central system, then up your spinal column into the brain. So if I walked up and I pinched the bottom of your leg, it would go through your peripheral to your central, straight up into your brainstem, into your brain. Anyway. So there are 12 pairs of cranial nerves. There are interesting ways to remember these things. And as you know, EMS is a dirty situation. So there's always dirty acronyms for this, which I will not put on a recorded lecture, but I will tell you guys later on. But there are ways to remember this. And there's all different types. Yeah. Yeah. Because your arms are different than your chest. So 18 front, 18 on the back, right? Interesting. If you take a test again, that question comes up, just screenshot it and text it to me. I'm curious to see what it is. Right, so 18 here, 18 on the back, okay? 9, 9. So basically it's 4.5, 4.5, right? They could have. That's 4.5, right? And then, right. Then you also want to look if it's circumferential as well as you go around. So the best way to do it, if you can't remember all the numbers off the top of your head, is your palm is 1%. You can kind of add it up to remember it. So there are 12 pairs of cranial nerves. They transmit information directly to or from the brain, right? So we have all different types of cranial nerves. One of the biggest ones that we deal with in the field is your 10th cranial nerve, which is your vagus nerve. That's a very important one because remember, the 10th cranial nerve is the vagus one. So if somebody were to sit here now, please don't do this at home because you're not near an ambulance because you pass out. If you sit there and bear down, like you're trying to poop, right? Please don't poop. Mode codes, yes. So what happens is they're trying to bear down because they're constipated and they sit there and they're trying to push it out. So if you were to sit here now and try to bear down, okay, literally try to bear down, what's going to happen is your heart rate's going to drop and your blood pressure is going to drop. It is going to drop. Right. You're already on opiates. You're already constipated as it is. So you try to push that stuff out and then you pass out and then you don't recover. You die. So we call them promote codes. Yes. Yeah, because they always code and they fall between the toilet and the wall and the shower and they can't get out. So with that being said, we stimulate the vagus nerve a lot with that kind of stuff. So that's actually one of the treatments for paramedic level is to vagus nerve stimulation by having someone blow into a syringe or blow into a straw or bear down to try to drop their heart rate if they're like an SVT. That's one of the first things that we can utilize called the vagal response. But yeah, because you're standing up too fast, right? Yeah, you get really dizzy. Yeah, that's where you check orthostatics. Yeah. Yeah, and you're like really dizzy. So you stimulated that vagus nerve. So 10th cranial nerve, vagus nerve is the most important one to remember out of all those, especially at the EMT level. There are two types of peripheral nerves: there's sensory and motor, which is why we do CSMs. I don't like using PMS because it said to a lady one time, hey, I'm going to check your PMS. Almost got slapped. Don't worry, sensory functions. So we checked about sensory nerves. So they carry only one type of information from the body to the brain via the spinal cord is sensory only. Right. The motor nerves, there's one for each muscle, and they carry information to the central nervous system, to the muscles, right? So muscles all over the body, including your head, muscles everywhere. And for us to be able to check motor function, so if I were to go to Steve, I know you're, and say, let me grip my hands, takes my fingers, and grips them. Okay. Steve, Sean. Both S's. Right. So if I were to go to Steve and say, let me see your hands for a minute, I'm going to squeeze his hands, right? They're going to squeeze my hands. I had it backwards. My mistake. We're going to make sure grips are equal, right? So another word of advice as well when you're doing that, have them squeeze your hands. Never do 3 fingers, okay? Because that can cause a lot of pain. So if I had Sean come up here and I squeezed all 3 of his fingers, I could break your fingers that way. 2 fingers, okay? I can squeeze all day long. It's not going to hurt. Give me 3 of your fingers, and I can probably break your fingers. Okay, so 2 fingers with them grabbed, and make sure grips are equal. Okay. All right, and don't be surprised. Elderly they have some good grips. I was like, do you still work out? And so these guys are strong too. So keep this kind of stuff in mind when you're doing that assessment. You want equal grips, right? Nice and equal. So checking motor nerve, motor function. The connecting we go. The connecting nerves are found only in the brain and the spinal cord. They connect sensory and motor nerves with short fibers and allow for it to exchange of simple messages. So simple stuff, ouch, that hurts, to hot surfaces, to stabbing, pinching, simple things. Controls virtually all the body's activities, including reflex activities, voluntary and involuntary, as well for the nervous system. Remember, involuntary being breathing, right? Being one of them, part of your muscle movements. That's an involuntary function. Because your central nervous system involuntary stuff may not have been affected. Yep. It all depends on what part of the brain was affected. And depending on what kind of overdose it was too. If it was opiates, then was he hypoxic, and how long was he hypoxic for? You know, so really a lot of that. Just checking with other people online, which is really good. So it controls the reflex activities, voluntary. So picking stuff up, voluntary movements, or involuntary activities like breathing. So connecting nerves in the spinal cord from the reflex arc. So this is if a sensory nerve in this arc detects an irritating stimulus, it bypasses the brain and sends a message directly to a motor nerve. Okay. So if it's something that's serious, an irritating stimulus. As you can see here, this is the heat source. It bypasses and just doesn't even pull away. So if someone's getting burned, let's say this is a hot surface, I do this. I'm having a conversation with you and I'm just talking and I'm just burning a hole in my hand. I don't feel it. Is that bad? Right? Are there people out there that have, I don't remember the name of it, someone knows the name of it online or here? It's a disease process you have no sensory feeling. And you're perfectly normal. There's a name for that. I can't think of what it's called. You can look it up, it'd be even better. But there's a name for that, not having any sensory, and someone can live with that. They would never know they bleed to death. I have no idea they're bleeding. Yep. As they're walking out of a house fire full of burns, but hey guys, and your skin is melting off. Yeah. Aaron, are you good? So obviously with a hot surface, as you can see, it bypasses quickly from here. It goes back and says, oh, pull that away. So voluntary activities are activities we consciously perform. So again, picking up a baseball and throwing it is consciously performed. Involuntary activities are actions that are not under conscious control. Now, can you change your breathing pattern on your own? Absolutely. But if we're just sleeping at night, or what's another one too? Is bowels, right? That's all involuntary. It goes through your system, it comes back out. Granted, towards the end, you can probably push it out, but everything's being done on its own, right? Through voluntary muscle movement. Somatic voluntary nerves handles voluntary activities as well. The somatic voluntary nervous system. The autonomic involuntary nervous system handles body functions. So we talked about the two that are there are the parasympathetic and the sympathetic nervous system, which we covered a little bit before. Now, there's medications out there that can stimulate or mimic these systems that we talked about during pharmacology, and that's another thing that you need to pay attention to as well with medication, people taking certain meds. Okay, so they're divided in two sections. We have the sympathetic and parasympathetic nervous system. The sympathetic nervous system reacts to stress with a fight or flight response. So if I walked up to Sean right now and I punched him in the face, he's got two options. Either he can fight me, or he's going to flight and run away. That's just two options. He's not going to, what they used to call the parasympathetic, used to be called the feed or breed. Okay, it runs your digestive system to slow down. if I hit him right now, he's either going to fight me back because his sympathetic nervous system will kick in, which means your heart rate will go up, right? So you'll start to you'll be stimulated, okay? And he's either going to run really fast away or he's going to come back and protect himself and attack you back, okay, to protect himself. That's your fight or flight system. It does. So inside of that is something called a neurotransmitter. There's two neurotransmitters. There's the neurotransmitter for sympathetic, and then the parasympathetic has a neurotransmitter as well. Sympathetic neurotransmitter is norepinephrine. So epinephrine, yes, but norepi is what it creates. It's your parasympathetic, it's your sympathetic neurotransmitter. So norepinephrine gets released in the system, causing your heart rate to go up, causing your pupils to dilate, also to constrict. So you get things bigger, you're waking right up and you're ready to go, right? Versus your parasympathetic that releases a neurotransmitter called, remember what that one was? Acetylcholine. Okay. Acetylcholine. Another name for it is ACH. If that gets released in your system, it happens when you're sleeping. Because when you sleep, your heart rate drops down, right? So your parasympathetic system can be stimulated, causing tachycardia. You can have your pupils start to constrict a little bit more. So, like opiates, they depress stuff, right? And it kind of stimulates the parasympathetic system a little bit. Versus a true parasympathetic stimulant, which would be something like organophosphates, right? That causes significant bradycardia. Versus people that are on blank what's called. Well, meth, cocaine, things like that. They're yeah, I'm trying to think of the name of it. Okay, that's it. It's right there. I just can't think of it. So I was drawing a blank. But stimulants. We call them stimulants for now. That will stimulate them, causing your heart rates to go up and things like that. People become more dilated. Right. Like uppers, yes. Like uppers. All right. So the skeletal system has the skull, which is composed of two groups of bones, right? The cranium, which is a thick shell above the eyes and ears that protects the brain, and then there's the facial bones. So, and I teach my 6-year-old these bones all the time, so she knows this stuff when she goes to school, so she can look somewhat smart when she goes. All right. So we have our cranium, top of the head, right? Okay. Nasal bone is here. What are these called? What are your cheekbones? These are the Z. It's a zygomatic bone, right? Goes into maxilla, right? Mandible down below here, right? Perfect. Then we have remember our skull is broken into 4 sections of bones as well, held together by suturing. Not like real sutures, but sutures, okay? And we have our frontal bone here, right? Parietal bones here, temporal, parietal, occipital bone, backbone, back there. The lobes in the skull are the same thing, as just one's bone, one's lobe. Right, frontal lobe protected by the frontal skull, frontal bone. That sounds broken down. And if you look here, in those squiggly lines you can see through there, those are called sutures, and there's names for the sutures as well, which you guys do not need to know, but they hold things together. That's what holds it together. All right, so the skull, this is going to be a long lecture, by the way. So the skull, cranium is composed of 80% brain tissue, 10% blood supply, and 10% CSF. Cerebral spinal fluid. Yeah. There are 4 major bones that make up the cranium. The occipital, yeah, oh my goodness, I can't talk today. Temples, parietal regions, and frontal regions, which you talked about already, the different bones. And the face is composed of 14 bones. The maxilla, zygomus, mandible, and orbits. So these are called the orbits that run around here. These are the orbits inside here. One of the very, very common fractures will be your orbital fractures, which you'll see the raccoon eye. You look at that. What? Right. Depending on how bad the fracture is. Because remember, you have the orbits here, and then just below that, here, your zygomatic bone. Times 2. The spinal column is broken into 33 vertebrae into five sections, which supports the central supporting structure, right, of the body. Your spinal column contains your central nervous system, your spinal cord, right, that allows all the nerve endings to come off going into your peripheral nervous system as well. Okay. So cervical 7, thoracic 12, lumbar 5. All right, sacral and coccyx 5 and 4. Your sacral and coccyx are fused vertebrae. They're one plate, as you can see here. So 7, 12, 5, 5, 4. That's your tailbone on the bottom. So injury to the vertebra can result in paralysis, because remember your central nervous system comes down as it splits, where you have that severed cord, or injury can paralyze from that point down, depending on where it is. Okay. The vertebrae are connected in ligaments and separated by cushions called intervertebral discs. Those are kind of like a cushion. So they talk about having a slip disc. That disc actually slides out, slips out. Ouch, a lot of pain. Spinal columns are almost entirely surrounded by muscle around it to protect it. That's part of your absorber, right? So with that being said, also remember that tendons connect muscle to bone, right? Ligaments connect bone to bone. Remember that too as well. We talked about that during A&P. So head injuries. Traumatic insult to the head may result in injury to soft tissue, bony structures, or the brain. There's 52,000 deaths that occur annually in the United States as a result of severe head injury, and accounts for more than half of all traumatic deaths or head injuries. So there's two types. So there's two types of head injuries. There's a closed head injury, it's obviously internal, and open injuries where you can actually see the injury itself. So the closed injuries, the brain has been injured, but there is no opening into the brain itself, okay? So less chance of infection, but if there's no fracture, where is that bleeding gonna go? It's gonna push. That's not good. All right, so open injuries, obviously an opening from the brain to the outside world exists. So now often comes with penetrating trauma, it may be bleeding and exposed brain tissue. Also, when it's open, now there's the entry for infection as well. All right. So motor vehicle crashes are the most common mechanism of injury for this kind of stuff. So head injuries, I got too soon for that. So head injuries are also commonly occur in victims of an assault when elderly people fall. And those are not just falling, but also questioning them a lot as well by looking at blood thinners and things like that when they do fall. During sport-related incidents and a variety of incidents involving children from falls. I've had 1-year-olds that have had head bleeds before, and I've had to transfer to trauma centers from hospitals before because they've fallen. That too. Yep. But I mean, when I was working in Mass, I used to get a lot of kid injuries, infant injuries, where they've fallen down a flight of stairs, and they were falling, and down they went, head over tea kettle. So we would have that, and then we bring them to Boston Children's right away, transfer right there. But up here, you got to go to your closest facilities, and there's no real pediatric centers that you go to Maine Med or Dartmouth, right, or Boston. So a lot of times there's significant trauma of kids, and flight might be the best option for that, or you go to your local hospital, and they're going to be calling for flight to get them out of there. Yeah, depending on the situation. Any head injury is potentially serious, because it could be the simple fall down and go boom. We call the FDGB, fall down, go boom. At a nursing home, whatever, and they place them back in bed, or they get transferred to a hospital for eval. They go through a head CT and they find nothing wrong. But that bleed might be so small that CT will not pick that up right away. But a week later, they're unconscious in bed, and they're like, "We don't know why he's unconscious." Question to ask is, has he had any recent falls? Well, he was transported last week for a fall, and he's on blood thinners. Oh, okay, probably a head bleed. Yep. Absolutely. So this is the general symptoms of a head injury. Thing on my screen. So there it is. So ecchymosis, but the eyes are behind the ears over the mastoid process. What they mean by that is that it's something called battle signs. So battle signs you'll find back here behind the ear, a lot of bruising. That's a sign of a basilar skull fracture. If you have battle signs back here, then basilar skull. Yeah, basilar skull fracture. Also contraindicated to put in NPAs if you have a basilar skull fracture because it can go into the brain because it's got an opening. Right, we don't want that. Bad things will happen there. Don't tickle the brain at all. So basilar skull fracture, battle signs behind the ears, a lot of significant bruising, and then raccoon eyes here, look like a raccoon. With that would be your orbital fracture. So scalp lacerations can be minor or serious, depends on how big the laceration is. But even the smallest laceration, because your head is so vascular, it can look like a murder scene. How much blood will come out of someone's head, and it's like a cut this big. So apply pressure, wrap it. Maybe severe enough to cause hypovolemic shock. You can bleed a lot. They're often an indicator of deeper, more serious injuries too. So you don't know what else is going on below that. That's why they need to get CTs done. Significant force applied to the head may also cause a skull fracture as well. All right, so we started at what, 9:30, so it's been an hour. Let's take 5 minutes. Okay, guys online, we'll take 5. I'll come right back. So we'll come back at 10:40. All right, I'm going to pause the recordings for this.
This conference will now be recorded.
All right, so back to recording. So with the skull fracture, we talked about significant force applied to the head may also cause a skull fracture. Unfortunately, you guys aren't in the class here, so I couldn't show you what I was looking at. I showed some of the students here a picture on my phone of a 9-year-old with permission from the family to show this in my lectures and classes. He was wearing a helmet, hit a tree skiing, and caused significant fracture, which caused him to be flown to Dartmouth and intubated in the field because of it. Maybe open or closed depending on whether there is an overlying laceration of the scalp. So again, we don't know. And injuries from bullets or other penetrating weapons often result in skull fractures as well. So we just have to pay attention and look for those kind of signs and symptoms. Signs of a skull fracture include a patient's head appears to be deformed, visible cracks in the skull, ecchymosis or bruising that develops under the eyes. We talked about raccoon eyes again for orbital fractures. Ecchymosis that develops behind the ear, one ear over the mastoid process. So over here on the face, that would be called battle signs, which we talked about as well. Here are some pictures of those. So there's your battle signs and there's your raccoon eyes. So you see these in elderly with falls a lot. Okay. So those are the 2 pictures up there. I think they just switched over, you guys. All right, moving forward. Linear skull fractures, we talked about here a little bit. This is called a linear skull fracture. You see on the picture up on the screen. They account for about 80% of all skull fractures, and radiographs are required to diagnose linear skull fractures because there are no physical signs. Again, so we see a lot of these in the ERs when I was working there. These patients here would be transferred to Portsmouth for neuro, usually. So these patients here need to go to trauma centers. Yeah. Depressed skull fractures, I mean, these here you can actually feel during your assessment. You'll be feeling the head. Don't push hard, just kind of rub your fingers over and you'll feel like the indents. These are called depressed skull fractures, results from high energy trauma, direct trauma to the head with a blunt object. So frontal and parietal bones are most susceptible to these types of injuries. Oh yeah, yeah. But again, you don't want to push down too hard because it's pushing against the brain. So you want to kind of feel crunchiness underneath your fingers. And bone fractures may be driven into the brain. So again, like you don't want to push too hard. But if you do this here and you feel the indent, you're like, ooh, that feels a little spongy. That's not good. That would be more of your depressed skull. Basilar skull fractures, and the basilar skull, which we talked about behind the ears here, associated with high energy trauma, usually occurring following a diffuse impact to the head. And signs include CSF drainage from the ears, raccoon eyes, or battle signs. Because you'll see the swelling from here starts going towards the eyes. The blood's got to go somewhere. Again, halo checks. As you can see, the blood coming from the ear. Just collect some, look for that yellow ring. See that, then you have CSF leakage. Open skull fractures, like in the picture up here that you see, obviously result from severe forces applied to the head, often associated with trauma to multiple body systems at this point because it's done that much damage. Brain tissue can also be exposed to the environment as well, so you can actually have brain matter coming out. It can be, but also significant trauma, like hitting it off like a post of a car, cutting it right open, and fracturing that way. Because I mean, granted, yes, the bone of the head is really secure, and like, I can push on my head and it's okay, but it's not that thick, so you can break right through. So significant forces, as you saw. I mean, the kid hit a tree with a helmet on. It had enough to actually. Then it was depressed. It wasn't open, but enough to depress it, break it, so then rip the top layer off. And you got an open skull. TBIs are the most serious of head injuries. There are two broad categories: primary direct injury or secondary indirect injury. So primary brain injuries result instantaneously from impact to the head, and the secondary brain injury increases the severity of the primary injury. So basically, just over time, it gets worse and worse. Secondary injuries also may be caused as well from hypoxia, hypotension, cerebral edema, intracranial hemorrhage, intracranial pressure, ICP, cerebral ischemia or infection can cause that. So patients that are brain dead because of whether it be like the overdose you were talking about to infection to whatever that have significant deficit afterwards, these are your secondary injuries that we're talking about, or hypoxia. So if you have patients that are COPD exacerbation, or even with COVID now, where their pulse oximetry drops so low they're not getting that oxygen, or patients that are caught in carbon monoxide issues, where they've been under carbon monoxide for so long, can cause severe hypoxia. They can have anoxic brain injuries. For that can turn into a TBI if they can't recover. Yeah. Good. Yeah, so a lot of this stuff can happen from secondary injuries, caused by something else as well. Strokes can cause that kind of stuff too, as well. So the brain can be injured directly by a penetrating object or indirectly as a result of an external force. So the counter-coup injury can result from striking a windshield. So again, they hit the steering wheel, windshield, and then the back and forth movements. which we talked about already. So intracranial pressure, obviously accumulations of blood within the skull or swelling of the brain can rapidly lead to increased ICP, which increased ICP then squeezes the brain against the bony prominences within the cranium, so it's causing pressure. So there is something called, let's see if it brings it up first. Yeah, Cushing's reflex. I had to read the bottom of that. So yeah, we're talking about Cushing's reflex versus Cushing's syndrome. Cushing's syndrome is an overproduction of cortisol causing like moon face, like swelling all the time. But Cushing's triad or Cushing's reflex, same thing, are three things that indicate intracranial pressure of greater than usually 10 psi of the brain. So signs and symptoms of this would be Cheyenne-Stokes respirations or ataxic buyout respirations or irregular respiratory pattern. Decreased pulse rate, so bradycardia is the next one as well. So headache, nausea, vomiting, decreased alertness, bradycardia, sluggish reaction to cerebit posturing, and increased or widened blood pressure. So the three things they look for Cushing's reflex, okay, or the Cushing's triad, this is something you guys need to know this, okay, because you want to pick up on this in the field. Irregular respirations, bradycardia, hypotension. You have those three things, okay? So bradycardia, irregular respiratory drive, and that's Cushing's triad or Cushing's reflex, which would be your increased intracranial pressure. It's the irregular respiratory pattern. So it's kind of like, kind of just changes, irregular changes your patterns. So patients that have the Cushing's triad we want to pick up on in the field, obviously, as a list of those steps. Intracranial hemorrhage is the next one for as well. So bleeding inside the skull also increases ICP. Bleeding can occur between the skull and the dura mater, beneath the dura mater, but outside the brain, or within the tissue of the brain itself. Okay. So we have these different types of bleeds that are there. If the skull is still intact and it doesn't bleed out, then it has to bleed somewhere, right? And it's not going to stop. So it's going to keep bleeding and bleeding, causing more pressure in the brain to push stuff. That's where you start seeing your midline shifts. So this is called an epidural hematoma, as you can see here looking at the picture. So your dura mater is here, epidural below, pushing into the brain from the dura mater area. Accumulation of blood between the skull and the dura mater, and the blood pushes the brain head. It's called a subdural, or it's an epidural hematoma. Nearly always result of a blow to the head that produces a linear fracture. We talked about linear fractures, that's what you see on a CT. So we've had patients that have come in that have been alert-oriented before in the ER that have gone to get a CT done and said, "Oh, you have head bleed." I do. It's going to get worse. These patients then are arranged for transfer down to Portsmouth Hospital with a neuro. All right. This is called a subdural hematoma. So accumulation of blood beneath the dura mater, but outside the brain still. It's not bleeding into the brain, which would be your epidural, which we just talked about. Occurs after falls or injuries involving strong deceleration forces. And then may or may not be a skull fracture present. So it can cause damage, but not actually. So a fall can cause this, but actually a fracture to still cause that bruising underneath and that bleed and the swelling. The intracerebral hematoma is bleeding within the brain tissue itself and can occur following penetrating injury to the head because of the rapid deceleration forces. You can kind of see the bleeding here, but it's inside. All right, these patients here, any kind of patient that has these types of bleeds, sometimes when you have a hole drilled, relieve that pressure and drain the blood out. This is called a subarachnoid hemorrhage or subarachnoid bleed. Bleeding occurs from a subarachnoid space where there is CSF circulates inside, so the arachnoid area I talked about before, resulting in bloody CSF and signs of meningeal irritation. The common causes include trauma or rupture of an aneurysm. As long as it's taken care of fast enough in a neurocenter or neurosurgery. So the closest one to here is Portsmouth Hospital. They can do neurosurgery there now. It is now. The only thing, so Portsmouth Hospital, Dartmouth, and Maine Med can do all the same stuff for neuro. They have 24-hour neurosurgeons on board now. The only thing keeping Portsmouth being a level 1 trauma center is they don't have a teaching affiliation with a major university yet. I know they're working on that. That's part of the level 1 trauma center is having that teaching facility. So they have all the residents and everything else over there, which is pretty cool. Yes, I know. We have 3 that are recording now online. They're currently online with us. And the rest of them are actually, I knew they weren't going to be here. Yeah. I like it. I only saw it from a distance, but not bad. You're, take a look at the touch. I will. After. We finished this lecture about, we're only at 56 of 155, so. Yeah, we've been doing a lot of discussion though on head trauma, so there's a lot to it. So with a concussion, obviously is a blow to the head or face that may cause the concussion of the brain itself. So we got to pay attention to those, pick up the signs and symptoms. What do you think those would be? Has anybody ever had a concussion in the room? I'm sure. So how did you feel with that? Tired, right? Sleepiness, what else?
Not really.
Getting not oriented. So wanting to fall asleep a lot, not oriented very often, and that's another thing that happens with that. Vomiting, okay? Nausea, vomiting constantly. And people blow it off. So like high schools now, when you look at sports programs, they have concussion protocols now. Usually if you have one concussion, you're like done for the season now in high schools. So that's why a lot of kids don't report it, because they don't want to lose their season, which can be very dangerous. And that can lead into something like a TBI if it isn't treated. So again, we have to pay close attention to pick up the signs and symptoms in the field of concussion syndrome. So closed injury with a temporary loss of alteration or part of or all of the brain's abilities to function without demonstrable physical damage to the brain. About 90% of the patients do not experience a loss of consciousness, but they've had the type of injury. Did you have loss of consciousness? You were out? You're like, what is going on? So a patient with a concussion may be confused or have amnesia as well, not remember what's going on. So usually a concussion lasts only a short time. So when we're doing our assessment, even with concussion stuff or the amnesic part of it, we want to ask them some short-term memory questions, okay? So usually I start with, obviously, month, day, year present, trying to find how alert they currently are, but I'm going to ask them some short-term questions as well. Can you please remember these 4 items, okay? If you say, or 4 things, purple, pink, yellow, penny. Make sure you know what you're asking them, so in 5 minutes from now when you ask them again, you know what you asked them, so write it down or use the same things over and over again that you would use for a patient, and see if they can recite those again in 5 minutes. Say, please remember, yellow, purple, pink, penny, whatever you want to use. And if they remember that in 5 minutes from then, then their short-term memory is actually pretty good. If they go, I don't remember any of it at all, then they may have some amnesic properties there. Repeated questioning also. But again, elderly, though, you have to be careful of that too, because if they have dementia, they're going to add, or Alzheimer's, they're going to probably repeatedly question you as well. But if you have a kid, this shouldn't be happening. Let's say I have a predisposed condition, so ask those questions. Check that short-term disability stuff as well. Short-term disability, short-term memory questions. This is not orientation today. So make sure you ask those appropriate questions. Ask them about the symptoms of dizziness, weakness, visual changes, nausea, vomiting, ringing in the ears, slurred speech, and inability to focus. We're going to look at those questioning. Look for lack of coordination. Ask them. They may not be honest with you, so try to test them on some stuff. Coordination skills, things like that. Can you stack, these 4x4s in one spot? Make sure they're even. See if they got the coordination to do that kind of stuff. Delayed motor functions. Can you squeeze my hands? And then like 10 seconds later, they squeeze your hands. That's a delayed motor function, right? Can you take your fingers and can you touch them to your nose like this? This is a good neuro assessment too. And start doing this, like that. Temporary headaches, disorientation as well. They're far more serious than a concussion is contusion. Involves physical injury to the brain its actual self. So true damage. May sustain long-lasting and even permanent damage of this. And the patients may exhibit any or all the same signs of a brain injury. Brain injuries can also arise from medical conditions such as blood clots or hemorrhages. We talked about those. We talked about strokes and or hemorrhagic versus occlusive, which you just had, the hemorrhagic stroke. You personally did not have one. Signs and symptoms of non-traumatic injuries are often the same as those of traumatic brain injuries. There is no obvious history of MOI or external evidences of trauma. So we have to do our stroke scales. So pronator drift, arms out, palms up, and see if they fall. Smile, combativeness. That's a lot of times I've seen more combative patients with head injuries versus not that have had hemorrhagic. I have not seen an occlusive stroke become very combative. I've seen it a couple times, very, very rare. Does it happen? But yeah, head injuries, hemorrhagic strokes, I've seen those become more combative or have just the unresponsive puckering of the lips or whatever. I've seen that a lot. Yep, usually. But he was unconscious, you said, right? No. But he was doing a lot of like that. Yep. Right. Yep. So that's another thing too, is the big one though is obviously that I've seen a lot in hemorrhagic though being combative being one is that puckering. Right. Hold on one second, guys. Wait. What's up? I'll take a break for 2 seconds. What's up? I have no idea what you just said. Yeah, I can now. All right, I'm back. So spinal injuries, obviously compression injuries that can result from a fall. So we got to really pay attention to spinal stuff with falls. All right, I've seen a lot of people just walk in for falls in homes, even like fall down, go boom, slip out of the bed. It doesn't take much to have a little bit of a tweak somewhere. Do a quick spinal assessment, CSM, before you stand them up. Okay. So compression injuries, obviously anything with compression, unlike the Colin Tuppenborough was more of a distraction injury. All right. Too soon. All right. Oh, EMS humor. All right. So compression stuff. So think about we see compression fractures and hyperextension, hyperflexion fractures with like diving injuries. So when they come in, if they hit and the head goes back, right? Hyperextension fractures. They come down, hyperflexion. So if you take your heads down and grab your hands back here and pull forward with that, but push, keep going now. Go beyond the point of feeling good. Then it starts to hurt, right? Okay. Right. Okay, then it starts to hurt a little more. That's hyperflexion. You're flexing so far, your vertebral pop. Okay. This feels, but that feels good, right? Okay. So if, and this is all about the compression stuff, but if I stand up here, okay, stand by, I'm doing a demonstration here. So turn around for a second, okay? Now if I grab your head like this and I turn like this, does that hurt? Okay. Hold her shoulders straight like this to the front. Okay. Now turn her body. Keep turning. It stops there, right? If I kept going, you feel the pain, right? Okay. So, but you see what I mean? Though we turn the body, so that's more of your the twisting motions. Your body, your neck can go a certain point. Once you pass that point, so, huh? Right. Or weird people that come out of the corn and exorcists and whatever. So, but all that is a hold on. So you can do certain things. If I push farther, or hyperextending, hyperflexing, or over twisting, that can cause those spinal cord injuries. Okay, and we see that. And surfing is one of the worst ones. When they come down, they hit the water, and the waves turning, it spins it. I talk a lot about that in my water classes and ocean safety stuff. I think you did right. Something, bro. All right. So compression fractures forces that compress the patient's vertebral body that can cause herniations of discs. So they come in, they push. So if I walked up to Kelsey's head and I pushed your head down like this here, we're compressing the spine. That stuff has to go somewhere. So your disc can pop right out. Okay. So motor vehicle crashes can overextend the spine as well. Rotation, flexion injuries of the spine result in rapid acceleration forces. So again, I just turn it and I did a rotation flexion, right? So like this. I can do this all day long. My spine will be hopefully 99% sure I'll be fine, right? But when I add that extra force in that goes beyond that point, the breaking point, that's when we start having our injuries. You got to consider that when you're looking at the crash. Okay, were they seatbelted, non-seatbelted? What happened? Where did their head end up? Is there scarring in the windshield? Is the steering wheel deformed? Is there any deformity underneath the dash? I'm looking at all that information there to say, here are all our external forces. Here's our patient, and they weren't wearing a seatbelt. Now I'm planning injury patterns. What could potentially go wrong when I do my assessment? That's what you guys need to think about when you walk up to a scene. Look at what you have and say, this could be wrong, this could be wrong, and this has to happen within like 20 seconds. Quick scan. That's broken, that's broken, that's broken, that's broken, and his body looks like he's broken, so I'm looking here, right? And that's how we assess our patient in a roundabout way. We still do our head to toe, but I'm going to put a little more focus on the high impact areas as well. So if I think there's a force enough that could hurt the spine, I'm going to protect the spine. Even if they're perfectly fine, I'm not going to rule out C-spine like we can. We can rule it out and do all of our assessment techniques and all that kind of stuff. But if the mechanism is actually there, why are we ruling it out? It's just a cervical collar, and that could save the guy's life. All he has to do is you can pass your test. He stands up and he walks away because he wants to do a refusal, right? Or let's say he wants to go to the hospital, and you stand him up and you walk him to the stretcher because he's ruled out C-spine, and someone goes, hey, and he does this, and down he goes, dead. All right? Let's do it the right way every time. Let's not half-ass it and cause potential injury because that's your license on the line. Justify why you just ruled that out when the guy rolled his vehicle over 7 times without a seatbelt on. Tell me how that's justifiable for a patient not to get a cervical collar at minimum, right? So we got to play all that into a factor, right? So again, spinal injuries, they can happen. Yes, they're very protected. Our body does a good job protecting it, but there's going to be an external force that's going to cause something to fracture. And you might not know it until they make that one turn. And then he breaks, and they severs C3 spinal cord, he's dead. So When the spine is pulled, like hyperextension across its length, this can also cause fractures too. So you can hyperextend back, or it can be like a distracting type deal, pulling. And one of the big ones we see for those are hangings. So I thought it was a little too soon, but since we're talking about it, any one of these unnatural motions, as well as excessive lateral bending, can result in a fracture or a neurological type deficit. Our body can do a lot of weird stuff, especially if you're very flexible. With certain things, there's a breaking point. It's got to stop. Okay. When bones of the spine are altered from traumatic forces, they can also fracture and move out of place. So always suspect a possible head injury or spinal injury with motor vehicle collisions, pedestrian motor vehicle, falls, blunt trauma, penetrating trauma to the head, neck, back, or torso. Always suspect a possible head injury or injury with rapid deceleration, hangings, axial loading injuries, or diving accidents. Diving accidents are one of the top 4 in the country of traumatic spinal injuries causing death. Top 4, okay, of injuries. Why do you think diving boards don't exist anymore, really? Okay. What was that? Yeah. I have some interesting videos of diving injuries that I use in my water classes. So, looking at getting into our assessment stuff here, and we're going to probably move this pretty fast, and a lot of it's still the same. Again, scene safety, BSI. Check for hazards. Remember, take care of your team. Be prepared. Wear appropriate PPE. Call for ALS as soon as possible. Looking at the MOI, which we talked about, looking at, all the indicators, as well as consider how the MOI produced the injuries expected. You've got to look and say, remember I mentioned before, look at your scene, all right? Guy fell 20 feet off a roof doing roofing, landed on the ground. Okay, what was the ground made of? Was it grass? Was it soft dirt? Was it concrete? Was it pavement? I mean, did he hit anything on the way down? Is there any scaffolding on the way down that he may have hit and bounced off of? Yeah. Right.
Oh, absolutely.
So the question is he not intoxicated?
Because if they're not intoxicated, that's what you worry.
Yeah. Why are you not drinking today? So those are some things to think about, is look at the injury patterns from where you fell, and that can help you determine the injury itself, kind of rough idea, but also what mechanism was there. You got to look at it as a whole. You have to document that. Patient fell 20 feet, bouncing off like a ping pong ball down the scaffolding. So boom, boom, head over tea kettle. Focus on identifying and managing life threats. So threat to circulation, ABCs, external hemorrhage. If they're bleeding out, tourniquet, move forward. If you can't stop it with direct pressure. All right. We don't elevate anymore like we used to back in the day. It's get the tourniquet, move on, because you still may have an airway issue. Okay. They put ABCs, airway, breathing, bleeding, circulation, but you can't. If you bleed out, no matter how much you do the airway, you're still dead. You got to stop that bleeding. But you have to work as a team. He works on bleeding, he works on airway, manage it. If you don't get the vital signs, you don't get the vital signs, because you got to manage that airway, manage that bleeding. Reduction of on-scene time recognition of critical patient increases the patient's chance of survival, or reduction in the amount of irreversible damage that may have already happened, right? We don't need to be on scene for 30, 40 minutes unless there's an extrication in process. Trauma patients need to get to trauma centers, and you have a golden hour to make this happen. And what they don't teach you anymore, which I think they still should, is a platinum 10. That's your first 10 minutes on scene and what you're going to do. Get the patient extricated, loaded into the ambulance, and start transporting and get ALS removed. No significant trauma. What was that? CQI? It does for me because I look for it. I look at. So you have to show a why in 20 minutes. You have 20-minute on scene time. Anything longer than that, our system, and I think temp system MEFRs also trigger it. You got to put a reason why you're on scene longer than 20 minutes. So then you put down other, then you have to document why it was other, or it could be extrication or whatever. But still, just because it's in a drop down, which is good, okay, that's used for national statistical data to help with protocol development and everything else. Put it in your narrative as well. Document that what happened. Because that's going to be important for a court case and why you were on scene for 40 minutes while the guy died. You know, and court cases take a long time. So to kind of bring up court cases and trauma, you guys remember hearing about that motorcycle crash that killed 7 people up in the Berlin area? That's what, a year and a half ago? That hasn't gone to trial yet. They just got some, all the EMTs just got subpoenaed for that. Yes. Okay. All the EMTs on there, because I know one of them, just got subpoenaed to go to court in March of 2022. So now take that run report that this person wrote in 2019, okay? Now you're in 2022 and you got to justify that run report from 3 years later. Okay? That's why it's important to document. These guys all have to go and testify in court for what happened. So how important is it to document? Just saying. And use your drop downs. Because now these people, friends of mine, have to now go to court for this. So I have my theory behind all this, but and it's not the riders. Focus on identifying life threats. We talked about reduction of scene time for irreversible damage. Spinal mobilization considerations. Obviously, assess the patient in the position found. Don't make them stand up and start moving until you do your assessment. Okay, these are not patients we walk to the ambulance from a motor vehicle accident. Okay, if the mechanism is there, assess them before you move them. All right, determine whether or not the cervical collar needs to be applied. If the mechanism and the forces are there, apply it. Okay, that way you're protected. Now, the patient doesn't want it, okay, then have them document and sign a refusal form. Okay, there's nothing wrong with taking a patient refusal form, putting something on there, patient refuses cervical collar. Sign here, sir. Refusal of treatments, you know, and document. Assess the scene, determine the risk of injury, which we talked about already, and form a general impression based on the level of consciousness and chief complaint, sick or not sick. The backboard often places the patient in an anatomically incorrect position for a long period of time. Circulation of areas may become compromised because of this. Some patients could also experience respiratory compromise by laying flat to try to minimize the amount of time a patient is on a backboard. Get them off the boards. If they're on the ground, scoop them, because then there's less log rolling, right? All right, scoop, pick up, kick down, undo the scoop, sit them up a little bit so they can breathe better. As long as they're in line, that's all that matters. They don't have to be flat. As long as they're in line and they have a cervical column, they don't move their neck. All right. Back in the day with head blocks and everything else, they couldn't do anything. And they got claustrophobic and they freaked out. Now we're giving them more medication to knock them down. Cervical collar helps maintain spinal motion restrictions. The best time to apply the cervical collar depends on the patient's injuries. Okay. I live in a car. As I'm talking to the patient to get my assessment, collar goes on. Right? Someone's in the back seat holding C-spine until we move. Okay. Once cervical collar is on, do not remove it unless there's a problem maintaining the airways. Otherwise, we can take it off. And still, if you take it off for airway management, you need to document why you took that collar off. All it takes is one bump in the road and this to happen, and then so document everything that you do and why you did it, the cause, the effect. What happened? Assessing the signs and symptoms of head injury. Ask about the chief complaint. What's going on? What happened? Confused or slurred speech, repetitive questioning, or amnesia in response of adults is a good indication of a head injury. Which I believe you mentioned repetitive questioning, right? So that's one important part. And setting of the trauma, assume that your patient has a head injury until your assessment proves otherwise. Assessing for signs and symptoms. If the patient is found unresponsive, emergency responders, team members, and bystanders may have helpful information. Sample history. Unresponsive trauma patients should be assumed to have a spinal injury. So yep, you have a spinal injury. Work with it. Patients have decreased level of responsiveness should be considered to have a spinal injury based on their chief complaint. Now again, if it was anything involving trauma and they're not oriented, they get a collar. If you have any kind of ABC considerations, remember jaw thrust on head tilt chin lift. Jaw thrust maneuver is ineffective, then use head tilt chinless maneuver as a last resort. Okay, you can go to that, but try not to use it. Okay, because it does move the neck. Vomiting may occur in patients with head injuries. You've got to watch for vomiting. Jaw thrust, yeah, got to pop open. Irregular breathing may also be a result of ICP. So what are the three things we look for, and what is it called again? For Cushing's syndrome, regular respirations, yeah. Yeah, you said hyper, right? Okay, yeah, what's the third one? Which one is it? Which one is it? Bradycardia? That's what I heard you say, right? Remember, pulse oximeter value should be maintained above 90%. That's what we look for in the trauma patient. So oxygen is always indicated in patients with head or spinal injuries. Put them on a non-rebreather, put them on 10 liters, let it flow. Hyperventilation should be reserved for specific conditions. We, as EMTs, should not be hyperventilating patients. It's actually been proven since this presentation was written back in 2017 that hyperventilation actually causes more damage to the brain than it does actually helping. So we just normal ventilations. Only time we ever hyperventilate is we hyperoxygenate someone before we intubate them. So, and even still, we don't do a lot of that. So a pulse that is too slow in the setting of a head injury can indicate a serious condition. Yes. I have not seen a lot of Cushing's out there. I've been to a lot of trauma. I've probably seen it maybe 10 times in 22 years. So one of those things that you learn about and you forget about. Pay attention to it. You never know. Your first head trauma call you go on after you feel it could be something with Cushing's. Sets for signs and symptoms of shock. Control any major bleeding. A single episode of hypoperfusion in a patient with a head injury can also lead to significant brain damage or even death. They need to be oxygenated. The manner of transport, again, maintain stabilization. Suction should be readily available. Make sure you have it out. Unless they take it out of the package, so leave it inside, so it's still sterile, so you don't need it, you put it back. But again, just be ready to be able to flip the switch and start suctioning. Make sure your tubing and your yank tower are not separated, because it takes time to open packages. Ready to go. Okay, if it doesn't get used, you can put it back, right? But, well, that's okay. All right. So when you're talking about history taking, you want to investigate the chief complaints. Remember, you look at our sample and OPQRST, right? And write down through both of those. You also got to be alert for specific signs and symptoms as well as pertinent negatives. So is the patient having a chest pain, shortness of breath, dizziness, nausea, vomiting, headache, diarrhea, blurry vision? Ask them all these questions, okay? Kind of work on more tailoring your assessment. Then your allergies, medications, pertinent past medical history, last or intake of unseen illness or injury, what happened prior to. Was the motor vehicle accident a cause of a medical condition prior to, like blood sugar? Did someone hypoglycemic crash the car? Now there's significant stuff. Did they have, yeah. Did they have a heart attack and crash their vehicle? So those are some things you want to think about also when you're doing your assessments. And then when did it happen? Did they make the pain better or worse? What's the quality of pain? Is it sharp? Is it dull? Is it pressure? Is it stabbing feeling? Does the pain radiate anywhere? Shoulders, back, neck, abdomen, right? Looking at the severity scale, 0 being no pain, and 10 being the worst pain you ever felt in your life, right? 0 to 10. 0 is no pain. And then I'll see how long has it been going on for, time range, right? As far as that. Or you're going to instruct the patient to keep still and not to move their head or neck. You want to ensure they keep still, okay? So when you approach your victim, like right now I'm in perfect line with Kelsey, I'm not going to approach her from the side and say, hey, how you feeling? She does this, right? Okay, go to the front and say, please don't move your head or neck. I'm going to ask some questions. Someone's going to come behind you and hold your neck still. Right? Do you understand what I'm saying? Yes. So come up back, they're going to grab your head. Because now you've got permission of what's going to happen. You don't mind it happening, so now I can physically touch your head. Make sure you don't move it back and forth, right? And we're going to get a cervical collar placed, and we're going to work on our assessment. Maybe a systematic head to toe full body scan of a systematic assessment that focuses on certain areas of the region of the body. You need to touch people in this field of work. All right? We're not doing it to get a thrill. We're doing it because it's our job. Okay? That's why it's hard sometimes with very young 18-year-old EMTs that come out of school. They're like, now you need to assess this 30-year-old woman. You need to touch her. And you notice that they're fine here until they get to this region, and then they're like and to the abdomen, get back to the chest because I need to know if they have any flail segment, right? Crepitus. You got to assess the ribs. You got to assess equal rise and fall, and you got to assess the sternum. And they bypass it all because they feel uncomfortable because they're 18 touching a 30-year-old woman. You know, it happens, and we got to look past that and know that we have a job to do. And just remember, what was that? That's right. So vital signs, significant head injuries may cause the pulse to be slow and the BP to rise. That's when we talked about Cushing's. With neurogenic shock, the blood pressure may drop and the heart rate may increase to compensate for neurogenic shock or spinal shock. Respirations may also become erratic, so use monitoring devices to help you with this. Okay, the cardiac monitoring will help you a lot with the respiratory patterns and not patterns, but respiratory rates as well, because it measures off the forelead. Right, and tidal, another phenomenal tool to put on somebody. 12 leads there. I'd have to see what Maine's going to. I haven't done the update for Maine yet. Every time I try to get it, we get calls. So, yeah. So, perform a full body scan using decap BTLS. So, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. Then examine the head, chest, abdomen, extremities, and back. Then check perfusion. So, cap refill, right? Motor function. Can you squeeze my hands? Sensory. Can you feel this? Right? Perfusion, check for pulses as well. In all extremities prior to moving the patient. We want to have a baseline before we start moving stuff around. A decreased level of consciousness is the most reliable sign of a head injury. Look for leaking blood or CSF. Assess pupil size and reaction to light and continue to monitor the pupils during the transport. That things can change. Do not probe or open scalp lacerations with your gloved finger. Okay, as much as it's fun to be touching someone else's brain, okay, we can't do that. Right? If you start poking and their hand starts doing this because you're poking their brain, it's not fun to watch. But we don't want to actually do that. Okay. Let's see. As far as our neurologic exam go, perform a baseline assessment using the Glasgow Coma Scale. What is that? What's a GCS? Yeah. Motor functions and verbal. Okay. And what's the lowest score you can get? Oh, no. So 3 is the lowest score you can get on a GCS score, and the highest score you can get is 15. So your eye movement measures a scale of what to what? What numbers? Eye is up to 4, 1 to 4. Verbal is 1 to 5. And motor function is 1 to 6. Okay, and part of your motor function is also posturing if you get down lower. So you have 2 types of posturing that would indicate brainstem issues. What are the 2 posturings to look for? Posturing. What are they called? Do you remember? The part of your motor function scale. So you look at motor function, obeys commands, localizes pains, withdraws to pain, abnormal flexion, and abnormal extension. So This is flexion, right? When they come like this, the boxer stance. This is called the corticate posture. Okay, like a, what was that? The corticate. I had to pronounce it out. Yeah, so the corticate posturing is like this. Okay, the cerebral posturing is when they come out like this, they extend laterally like that. Okay, this is very bad. Okay, that's almost like, okay, that's very bad brain herniation of some sort. Is the cerebral posturing that's stiff. Okay. Yeah, go ahead and remember it. So the corticate, the cerebral posturing. Okay, those are part of your neural assessments. So what you see up on the screen now is your Glasgow Coma Scale. If you don't know this, this is going to become a huge issue for your national registry. You have to have these memorized. And it's easier for you to take a screen picture of this on the wall than do that. You guys back at home on the screen, you can take a screenshot with your phone. This is something you need to memorize because this is very important in your trauma assessment. So GCS score, okay? So we'll go about, so we can try to get a little bit closer to this 5-minute break. Or you guys just want to run through this until lunch and get it done? Okay, so let's go through it till lunchtime. Once it's done, we'll take an hour lunch, come back to the next lecture. This is a long one, that's why I put it on a Sunday. So inspect for decap ETLs and check for extremity and circulation motor sensory problems, so CSMs. If there is impairment, note the level of impairment that there is, okay? So if they have any motor issues, you need to document your motor issues in your narrative. Pain or tenderness when you palpate the spinal area is a warning sign that there's an issue. Okay, but also check for chronic back pain. Ask appropriate questions for past medical history. And having spinal issues is a pertinent history. Right. Other signs and symptoms include deformity, numbness, weakness, and tingling of the extremities or soft tissue injuries. So remember when you're assessing, looking for needles, feelings versus movements, and everything. So make sure you get a good, thorough assessment. So you guys should already be doing this when we practice our trauma assessments now as it is. Repeat the primary assessment on your reassessment. So go back and repeat it. Reassess vital signs and chief complaint. Remember, 5 minutes for non-stable patients. Stable patients get every 15. Interventions, obviously multiple interventions may be necessary in patients with a head or spinal injury. So compare baseline vitals and repeat vital sign changes. So you want to get that trend as we're going, right? So we're going to trend and see where things are going to go. We have a baseline and trend. This will help you let you know if your treatments have been effective or not when you're doing your assessment. You'll also notice deterioration when the conscious patient's awareness of time, person, place, and event in that order. So again, time, place, person, the self. So I do person, place, time, and event, month, day, year, president, I usually use. But you want to ask those questions repeatedly. So I'm just going to check again. What month are we in? What day of the week is it? What year is it? Who's our current president? You never know. Things can change during transport. You start seeing a different mentation. All right. Interventions, again, you must act quickly to evaluate and treat these patients. If CSF is present, cover the wound with a sterile gauze, but do not bandage tightly. You don't want to push that stuff back in. It's coming out for a reason. Let's find out why. All right, let's go to the hospital. Administer high flow O2 and apply a cervical collar. Your documentation should include the history that you have obtained, your findings during your assessment, treatments you provided, and how the patient responded to your treatments. So, yes. Exactly. Just put something over it. That's it. That's where it's coming out of. It's coming out of that. Yeah, that means it's already been punctured and stuff's coming through. It's leaking.
Bigger issues.
Yes. So we're going to kind of collect it, but just put it some gauze over it. Don't stuff it in and just let it collect into that. Nope. No, they're going to need some surgical intervention at that point. All right, so 3 general principles in head injury care. 1, establish inadequate airway. Okay, this is patients that have significant head trauma sometimes need to be intubated to protect their airway because vomiting, that's the biggest thing. Aspiration is going to kill somebody. It causes aspiration pneumonia. Pneumonia kills people. All right, so a lot of times patients that have significant head trauma will be called for RSI and they get intubated in the field. So life flight, us in another month or so, we should have it here. And we'll be able to do that stuff in the field with the select medics that we have working with. 8 of us that can get it qualified. So again, CPR if needed. All right, and follow local standard precautions as well. Look at local protocol or safe protocols through traumatic arrest too. Okay, I don't want to give you guys main protocol because it's all changing. So for that. Assess patient's baseline for consciousness and continuously monitor these patients for transport. Manage the airway. The most important steps in establishing an adequate airway is perform the jaw thrust maneuver. And then you can insert an OPA if they don't have a gag reflex. If they do, they'll put it in. Okay. Head traumas, you can use nasal airways. Again, this is street stuff. Just keep in mind that if they have a skull fracture of some sort, you got to be very careful putting them in. Okay. So emergency care to head injuries, you see here, C-spine collar. Managing the airway, remove any foreign bodies that are there, secretions or vomitus. So continuously suction the patient out. Check ventilations and then give supplemental O2 to any patient with suspected head injuries. CPR if needed. Active blood loss aggravates hypoxia, right? We're losing blood and we need red blood cells and hemoglobin to transport oxygen. If we don't have it, we need to put more oxygen into the system. This is why they become tachycardic and tachypnic, right? This is why it's happening. Indicates that, so shock is usually the result of hypovolemia. So again, if you see hypovolemic shock or you see signs and symptoms of hypovolemic shock, like mental status, tachycardia, tachypnea, hypotension, these patients need to be treated rapidly and quickly. Lay them down flat, keep them nice and warm, help with the oxygen transport. All right, give them oxygen, high flow, longer breather, 15 liters a minute, put it on their face and keep moving. Reassess your patient. Cushing's triad, obviously we talked hypertension, bradycardia, chain stoked respiration or biots, irregular respirations, and performed controlled hyperventilation if patient, again, positive pressure ventilation at a rate of 20 breaths a minute. Follow a protocol for that because a lot of patients that have this are not being hyperventilated anymore. Okay. So your best bet if you're at BLS level is contact med control and say, what would you like me to do next? They say hyperventilate, then hyperventilate. But get on the phone, consult with med control. Obviously, follow standard precautions and maintain patient's airway, keeping the spine in line for spinal injuries, and assess respirations and give supplemental O2. For airway management, again, we talked about this 1,000 times in this presentation, is jaw thrust. You got to open up the airway. After you open the airway, consider inserting an oral pharyngeal airway and make sure you have suction ready to go because you may trigger. Again, if you put it in, you don't know if they have a gag, you won't know until you put it in. And that gag reflex could trigger vomiting. If that's the case, you got to turn them on the side and suction out. That was the only bonus to having backboards at the time. It's easy to flip. So this is the jaw thrust maneuver that you see here. So mobilization of the cervical spine. Hey, Chris, do you need tools? You got enough? I got a full box in the back of my truck if you want to borrow some. Well, as long as I'm here. I got a big red one there. Okay, so immobilization of the head and trunk, so that way the bone fragments do not cause any further damage. So again, C-spine, holding C-spine, getting that collar placed, making sure their head doesn't do this. Right? What was that? How do you hyperventilate? It's just bagging it faster. Yeah. So again, if they're breathing on their own though, and they're not hyperventilating, you got to control it. So anytime they take a breath in, you want to force air in, because if they're breathing out, you're just going to get that body type sound from the mask off gassing, right? You're bringing against the breath, so you got to get on the breath in. Now, if they're unresponsive and you can ventilate without an issue, then go 20 breaths a minute. All right. Sometimes it doesn't hurt to have a second person holding a good EC clamp, though, right? Unless you got big hands, right? It's hard to hold that clamp and give a ventilation, right? Like Paul showed you guys before too. When he was here, as he held it and using his arm like this. I'm not a huge fan of that, but if that's what works for you, fine. For me, holding an EC clamp's not an issue. I can really hold that down. So C-collars, which we talked about already, and also have done many C-collar applications during class here already, so we'll keep doing more of those. But again, it has to be a rigid collar, and you have to select the right size, because that will either hyperextend or hyperflex the head. It should rest on the patient's shoulders, the shoulder girdle, and provide good support. We're going to secure the patient, secure to a longboard or a vacuum mattress, which we don't carry vacuum mattresses over here, to get the patient for transport. Another procedure is using ground 2A backboard is a 4-person log roll. Again, if they're on the ground, you sit the patient on the count of 3, roll 1, 2, 3, up, underneath, back down again. So you may also slide the patient onto a backboard or vacuum mattress also from starting from the head here, putting the backboard up top and then sliding them up. So I can show you different things they taught in wilderness medicine and things like that, where they have position 1, 1A, 2, 2A, 3, 3A, and how to maneuver patients to get to the position you need to be in without compromising the spine and getting the movements. Again, that's wilderness medicine and also PHTLS to get the patients to maneuver without manipulating the spine. But that was back in the backboard days. Now that we're not using that anymore, 2017 to 2021, a lot of things have changed in spinal assessment compared to what it used to be. So we look at the shoulder here. You measure up to the corner of the jaw, number of fingers, and you measure on the collar itself. Make sure you set it. And one of the things that they can fail you on in your national is not popping them in place. You've got to lock them in. Because if it's not locked in, then it moves too much. The vacuum mattress is an alternative to the backboard. Again, molds in specific contours of the patient's body. So out west, I've seen these used on ambulances before. I've done a lot of reading on that, the vacuum mattresses. Literally, you can put somebody in any position you want. They have these molds to their body. Interesting. And yeah, this is a big splint. You put them in, you vacuum it out. Excellent for the elderly or a patient with abnormal curvature of the spine. What was that? Yes. Use a short backboard to restrict movement. These are sitting positions. The other thing you can also utilize for this here instead of the short board is a KED. Again, we don't even carry KEDs on the ambulances anymore because they're not even required in New Hampshire anymore. So you don't even get tested on it. We don't need them. We used to KED people all the time back in the day, but they don't require them anymore. I like keeping KEDs on the ambulance, but I like using them for pelvic fractures. Instead, I reverse it. Makes things a lot easier. Standing patients, mobilize a patient to a longboard before proceeding with the assessment. So they want you to do a standing sit, take down like this and down to the ground. Nowadays, bring the stretcher behind them, have them sit. So again, a lot of things have changed since this presentation. This is the most recent. Well, they have a new version that just came out like literally 2 weeks after we started the class. The newest edition came out. Thanks for telling me. So carefully lower the patient as a unit under direction of the EMT at the head. You have to bring the patient down. If you take lifeguarding courses in water rescue stuff, we still teach the standing takedown boards. Still part of it. Backboards? I think so, yeah, but no one ever uses them. So assume the position of spinal mobilization devices, assume the presence of spinal injury in all patients who have sustained high head injuries. Again, cervical collar, long backboard to get them out if you need to. Nowadays, they can get out, we have them stand, turn and sit. As long as they can keep their body in line as they move like this, that's perfectly fine. It's the twisting motions we don't want to do. So again, if you have to do a rapid extrication, you can't get the patient out without manipulating their spine, take the roof off the car, put a board underneath them, do a wrap underneath here like this, and sling and pull them up on the board and get them out. People still forget about the old school techniques that actually still work. And when I teach extrication classes, when I do an extrication class, I do a 16-hour tech program that I wrote, and part of that is patient removal. Not just how to cut the car, but how to get the patient out too. So the way I talk about it, even in trauma assessment, how to remove the wreck away from the patient, not the patient away from the wreck. That's what we're doing, the wreck away from the patient. If we don't want to move the patient, we want to get the wreck away. So what do we got to do to make that happen? What cuts we got to make, and what device we need to use to get that patient out. That's the best way to look at it. These are called KEDs, Kendrick Extrication Device. These were literally, they were designed initially for IndyCar. That's when they first come up with the Kendrick Extrication Device. These people have Indy cars because the way they are sit in, you have to lift them up and out. These have crotch harnesses too to lift as well. In one of my EMT classes, I put this on somebody and lifted them out of the jungle gym area using ropes. I'll show you pictures on the break. All right, these are longboards used to fully immobilize people. Helmet removal, we'll go over that in a couple of weeks. I'll bring a helmet in and we'll take off helmets as well. So the helmet should always stay intact, never taken off, unless there's airway compromise. That can be used as your collar to keep it still. Take the face shield off so you can see, but if there's airway compromise, then you have to go 2 hands inside the helmet and hold C-spine as they do this. That off. Yes, full helmets. Yeah. Now, a lot of times they're already off before you get there anyways. But if they're unconscious on the ground, the helmet needs to come off that one because now we don't know about airway management because they're unconscious and not talking to us. And you can't just take it like this and rip it off because that's in a full traction, right? So and always bring the helmet with you so the physicians can see the helmet and the damage. No, underneath. So you have to have small hands. You slip it underneath like this, and the other person will you're going to hold C-spine from the front like that. Okay, and then you're going to take it. You're going to go the chin and then the head come back like this to get it off. And if you have a third person, they can take it and pull it apart like that and hold it, so it spreads them more easier to come off. If not, and you can't get it off safely, then disengage the face shield so that you can see the eyes and have a conversation with them if you can't take it off. All right, so we already talked about how that comes off. Methods. So alternative method here, remove the chin strap, remove the face mask, pop the jaw pads out of place, hold your fingers inside the helmet, hold the jaw with one hand and the occiput and with the other side, insert padding behind the occiput deal. There are other methods you can utilize too, and they made these devices that you could slide in, like behind it here, and it slid up behind the head around the top of the head, and you just inflated it, a cuff, like that, and it lifted it up off the head. You've seen those before? So they made these specifically for like motocross and things like that, and some people had them on ambulances back in the day. I have not seen those since medic school. We were playing with them during medic school. I just don't see them anymore. All right. So let's go over the review questions here. And when we're done with the review, we'll take an hour lunch break. We'll come back. Okay. Yeah, I figured noon time, so not bad. So the brain, a part of the central nervous system, is divided into. All right. Is anybody else still online? I haven't been paying attention. Aaron, are you still there? I see Natasha and Kim had to take off. All right, let's just continue on. Anyways, so you guys said A. Answer is A. You are assessing a 24-year-old man with a large laceration to the top of his head. You should recall that. All right, B it is. A patient who experiences an immediate loss of consciousness followed by a lucid interval has a the epidural hematoma. Sorry, I hit the button too fast. I apologize. Right. Yep. A 44-year-old man was struck in the back of the head and was reportedly unconscious for approximately 30 seconds. He complains of severe headache and is seeing stars. He states that he has regained his memory shortly before your arrival. His presentation is most consistent with I'm seeing he's seeing head shaken. Correct. A young male was involved in a motor vehicle accident and experienced a closed head injury. He has no memory of the events leading up to the accident, but remembers that he was going to a birthday party. What is the correct term to use when documenting his memory loss? CNCs. All right, perfect. See, it is. A distraction injury to the cervical spine would most likely occur following So I got a C. What do you think? Said D. What do you got? A. So
Which one did you guys not go with?
go with B. All right, so 25% of getting it right here. The answer is D. Right? So excessive traction on the neck, such as occurs during a hanging type mechanism.
That was it.
That's weird.
This is the part. This was all it.
I've never seen that before.
Yeah.
All right, so we have 3 more to go, 7 or 4 more. During mobilization of a patient with a possible spinal injury, manual stabilization of the head must be maintained until what? D, A. You know what I just realized?
So are you gonna do?
They can't see my screen. They're just looking at C-spine.
So you have a known person with, obvious trauma.
Yeah,
You're not doing CSMs before you put a C-spine or a collar.
before and after it's considered a splint.
Right.
But you're going to hold manual first, and then they're going to put the C-collar on. So remember, this is going back to the whole longboard stuff.
So it would be D.
Okay, so I had to read the question again, just because I wanted to read it. What they're saying here, and I apologize for anybody online because your screens are just not changing. I don't know why. They're still stuck on the whole jaw thrust slide still. So what they're saying here is that until the head blocks are in place, you can't let go of manual stabilization. If you think about it, right? We don't use head blocks anymore. So
Right.
again,
That's kind of
so the national
that question could go anywhere.
It can. It can, you're right. Your patient is a 21-year-old male who has massive facial and head trauma after being assaulted. He is lying supine, is semi-conscious, and has blood in his mouth. You should do what? C. Immediate jeopardize must be removed before they aspirate, so suction out the airway. Can we go back?
Wasn't that?
Go back.
It's B.
They said take C-spine.
Yeah.
Right. So you have to hold C-spine first. So you guys said B, right? Okay. So your first instinct would be to airway. But if you snap the spine, they're dead.
Right.
So, but the thing is, though, is you're not wrong because maybe you already assume that C-spine is already being held. So what is the most appropriate answer? That's where the National Registry is going to trick you up. That's what they do.
Everything's always C-spine first
Yes.
before.
Yes. Hold C-spine ABCs because you can't open the airway until C-spine is being held. Right. So that's where they're going to trick people up. Forget the cervical collar. You don't put that on yet. Right. So you got to maintain the airway. So you don't have time to put a collar on, but you have time to hold it C-spine. And that's where they try to trick you.
If you have the manpower.
If you have the manpower.
If you don't have the manpower, then you're gonna.
Do you know how you do it? Put the patient's head between your legs.
Yeah.
And you just sit there and suction. You really can't roll with that at all. So you'd sit down like this here on the ground, put his head between your legs, and then squeeze with your thighs that hold C-spine. This is the real stuff, the field stuff that you learn. Okay. And literally the patient's unconscious. And granted, they got a crotch in their face. But you can literally get all the way down to the pelvis and do your assessment by leaning forward and walking and assessing. But if they wake up, that's the first thing they're going to see is your crotch in their face. So, but you're holding C-spine still. I've had to do that a couple of times. Usually they've been unconscious. You know, if they're conscious, I don't do that to them. So a man is found slumped over the steering wheel unconscious and making snoring sounds after an automobile accident. His head is turned to the side and his neck is flexed. You should do what? You're thinking B or C, you said? D. D. So snoring sounds indicate an airway problem. Usually for the snoring, usually the tongue's in the way. To manualize stabilization and get their head into a neutral inline position and then reassess. All right. Do not rotate or hyperextend the neck of the patient as possible. So this and back to normal. Yep. They figure this here could occlude it, right? Or if it's turned on with that. So you're going to take it. And as you're doing that, though, listen or feel for the cuppiness of the neck as you're doing it. Don't do this really fast. Go slow. And if you meet, so this is something they don't teach you guys in this program, and I don't know why they don't do this anymore. If you're moving the neck back and you meet resistance, don't force it, okay? Stop there and then stabilize the neck in that position. Because if there's something that's holding it in place, right, and there's let's say a disc is blown out or the bone fragments are out and it's making meet resistance, you pop it back into place. Yeah, stabilize in position. You should not remove an injured football player's helmet if. Should not. And look for those keywords in your national exams. So I got B. You say B or D?
B.
B. I like D. I like D also too. If the face guard can easily be removed and there is no airway compromise. I mean, I could be wrong. But. So breathing difficulty, we got to fix that. How do we fix breathing difficulty with a head, helmet on? You can't. Yep. And sometimes you have two answers that look pretty right. Which one's more right than the other? All right. So I'm going to stop this. All right. So I'm going to stop this lecture here. And then I might be able to stop it here. God, I can actually see my screen a little better now. All right, so I don't know if anybody else is still online. I see Aaron's still there. Not sure if you're still there or not. I will email you guys a new link for the next lecture in an hour. I'm going to shut this one right down and close it out. We'll come back for 1 p.m. All right, so be back for 1 p.m. with new link.